Hi, my name is Afsar Ali. I'm the head orthoptist at Kingsley. I'll be talking to you about fourth nerve palsies, the history about fourth nerve palsies, how the patients present with a double vision, what they mention, how we manage the double vision patients, and the anatomy of the cause of fourth nerve palsies as well. To begin with, I just want to mention, although the superior rectus and superior oblique are attached superiorly, superior rectus moves the eye up, however the superior oblique normally moves the eye down like that, okay? And I'll demonstrate it a little bit further in the next clip to show you why it actually moves down like that. Sure. So I've got Mr. Bala here, our senior ophthalmologist, who's going to help me with this demonstration. Both superior rectus and superior oblique are attached superiorly to the eyeball. However, the superior rectus pulls the eye up, but whereas the superior oblique pulls the eye down. Why is that? The reason is because of the way it's attached. Now, superior oblique is attached slightly posterior to the equator, and not only that, when the muscle actually pulls, it's almost like it goes through a pulley system. So I'm going to try and demonstrate the muscle. This would be the muscle. It goes through a pulley system where when you pull, it goes down there. You can see. And put it back, reset, and I'll do it again. When I pull, there, this is what the eye does, and that's how the eye looks downwards. So what we've got here is a gentleman who's got a right fourth nerve palsy. You'll be able to see that. I'll ask the gentleman to just look at this picture. Have a look at that, eyes wide open, and what you'll notice is the right eye coming down. That's a right hypertropia. There's also a little bit of exo, but particularly you want to focus on the fact that there's a right hypertropia. Okay, there. Good. Now we're going to do a demonstration of ocular movements. So if you have a look, and I'm moving him to laval version, what you'll notice is the right eye is lifting up. So this is what the right fourth nerve would show. You're actually noticing elevation of the right eye. This time we're going to take the patient down to, because I'm suspecting a right fourth nerve, down to laval depression, and here you should notice some weakness of the right eye moving down there. Now I'm going to move the patient to laval elevation, and you can see the right eye just suddenly shooting up now. So our right fourth nerve should usually be unaffected to the dextro version position. So there, having a look here, it looks fine, and he looks fine there as well. Okay, so if you have a look at the right fourth nerve patients on ocular movements, what will happen is as they look, right fourth nerve, you can see the right eye shooting up. That's this one. That's according to the Sherrington's law. Superior oblique should be pushing down, but because the muscle is weak, according to Sherrington's law, the inferior oblique is pulling unopposed, and that's why there's overaction of the inferior oblique there. So this gentleman is a right fourth nerve palsy. He came into the eye casualty yesterday complaining of double vision, which was particularly vertical. Now when you have vertical double vision, it could only be either a third nerve palsy or a fourth nerve palsy, and I'm going to show you how to actually distinguish between the two. Usually you'll find a Bichowski's head tilt test is useful as well. I'll show you at what point it's useful. Here, I'm gonna take your glasses off so then we can see the vertical. The patient here, and you're suspecting it's a right fourth nerve, but you can't actually see the vertical. One of the tips I can give you is that do a Bichowski's head tilt test, because when you do a Bichowski's head tilt test, so we're suspecting it's the right fourth nerve. Let's say we've done a Hess chart and we've seen on the Hess chart it's the right eye that's affected, but we can't see it on the cover test. What you do, you tilt the patient's head to the affected eye, which would be the right eye, and you'll see the vertical suddenly come out. If you want to further determine if the patient's got the right fourth nerve, patients themselves can help you a lot. You don't just have to do the investigation in silence. Ask the patient for feedback and they'll tell you a lot. So when you're doing the Bichowski's head tilt test, you tilt the patient to the affected eye. So we're suspecting a right fourth nerve. tilt the patient's head to the affected side. Ask them if the image separates more, okay? Because this is what you should anticipate, that there's more separation. And the reason is, if the right eye, the superior oblique is not working, the inferior oblique will lift the eye up further unopposed. So I'm going to tilt your head, or you tilt your head as much as you can. Did the image separate for you there more?
Yes, very much.
And you'll see vertical movements if you there.
Yeah.
And it's separated more. And that's more than when your head was straight, isn't it? So
Much
go back
more.
to your straight.
Yes.
Brilliant. Yeah. And now I'm going to tilt your head to the left-hand side as much as I can.
Yeah, that's perfect.
And it should come together, yeah?
Yes, that's perfect.
Okay, so that's fine. So it should. So this is what you'll expect with the Bichowskis. If you move to the unaffected side, it comes together. And if you move to the affected, it separates more. Zoom into this, yeah? So I've just done the Hess chart on this gentleman. And because we suspected a right fourth nerve, when you suspect a right fourth nerve, the muscle it controls is the superior oblique. So there's the right, and this is the muscle that it supports and innervates. So what happens is this cross, this black cross, is supposed to be touching here, but it didn't. It was a little bit shorter and a little bit weaker. And that's the pattern you're actually expecting. So you should see fairly normal all the way around there. You see all of the crosses that this gentleman actually corresponded to. These were fine. Now remember, you get two lines, outer line and inner line. Inner line always looks like a window, yeah? So there, it looks like a window. And they both actually assist you in diagnosing. So usually what I find, the inner line looks almost normal, but you get a subtle difference just here. So that cross should have been here, but in a normal patient. But with the right fourth nerve, you would actually expect this, a slight weakness. The other thing you'll see, according to Sherrington's law, is that if this is weak, the opposite muscles gets innervation as well. So what happens when this muscle is weak? There's innervation, extra innervation coming to this muscle so that it can actually get more strength, but it also gets extra innervation to all the normal muscles, and that's why the inferior oblique overacts. So there, that cross should have been here, but you've seen his eyes are working stronger just there. That's why it's gone up. This is our consultant ophthalmologist in ophthalmic primary care and cataract surgery, Mr. Mustafiz Rahman. Over to you.
Thank you, Afsar. So I'm going to talk about some anatomy just now. I'll try and keep it very simple because it can be often information overload. So the way the fourth cranial nerve sits, if we look at this model here, apologies, it's not the best model, but the fourth cranial nerve is there. So that's where it exits. And what that means is the way it sits within the skull itself means it's exposed. So I'm just putting the skull back. And as you can see, or if you could imagine there's a cross section there, that fourth nerve is sort of free hanging and susceptible to trauma. So if the patient was to undergo a head injury, like for example, if they're riding a bike and they fall off, then it can often present with a fourth nerve palsy. So what's important, as well as trauma being a common cause of fourth nerve palsy, it's important to be aware of the course in which the fourth nerve takes. The fourth nerve goes through the lateral wall of the cavernous sinus. So this is a structure which contains other nerves. So when you have a patient that has double vision that's vertical, so they're talking about vertical versus horizontal, it is important that we check all the cranial nerves, because if there's other cranial nerves involved, such as the sixth nerve, the third nerve, and also the V1 and V2 of the fifth nerve, then we need to think about the possibility of cavernous sinus involvement. And it enters the orbit, which is here, through the superior orbital fissure. So again, it's important, as there's other nerves that go through this, to check all the cranial nerves so that you can think of causes of superior orbital fissure syndrome.